This lecture will describe the ECG findings associated with over 20 illnesses and conditions, starting with atrial fibrillation. Atrial fibrillation, or just AFib for short, is the classic irregularly irregular rhythm. The atria transmit erratic and random impulses down to the ventricles, which simply put, results in a heart rate without any discernible pattern. To help describe the characteristic findings of AFib, we are going to focus on the rhythm strip of this ECG. While looking at this ECG, one of the first things that you might notice is that there aren't any P waves. Instead, we can see a quivering baseline with interspersed QRS complexes. These atrial undulations are the result of rapid and erratic atrial depolarizations and are referred to as fibrillatory waves. These fibrillatory waves can be either fine, less than 1 mm in amplitude, or coarse, greater than 1 mm in amplitude. When they are fine and have a low amplitude, they can appear as a smooth, wavy line, or even as a flat isoelectric line. These fibrillatory waves have no association with the randomly dispersed QRS complexes. When the fibrillatory waves are imperceptible, the underlying rhythm can still be recognized via the irregular RR intervals. With AFib, the RR intervals are generally unequal in duration. As in this ECG, some intervals will be longer, while others will be noticeably shorter. Closed group QRS complexes, however, may give the appearance of a regular rhythm. Furthermore, in the presence of complete heart block, a regular escape rhythm will be present. The most common finding of acute pericarditis is widespread elevation of the ST segment above the isoelectric line. Unlike with myocardial infarction, the ST segment is typically concave upward. While ST segment elevation occurs in most limb and precordial leads, it is usually normal or depressed in leads AVR and V1. A more specific finding for acute pericarditis than ST segment elevation is depression of the PR segment below the isoelectric line. It is also widespread, except in leads AVR and V1, in which it can be elevated. Atrial flutter is a macro reentrant dysrhythmia characterized by rapid flutter waves with a sawtooth appearance. The ectopic atrial depolarizations are called flutter waves. They are not P waves. These flutter waves are usually best visualized in the inferior leads, in which they have a V shape. In this case, the flutter waves are best visualized in V1, where they are positive deflections. The absence of an isoelectric line between the atrial flutter waves results in a sawtooth appearance. The flutter rate is typically between 250 and 350 per minute. This can be measured by dividing 60 by the time interval between the peaks or troughs of the flutter waves. Alternatively, divide 1500 by the number of small boxes between them. In this case, the flutter rate is about 375 per minute. Although the flutter rate can be very rapid, typically only a portion of impulses are conducted to the ventricles. Physiologic conduction delay at the AV node usually limits the AV conduction ratio to between 2:1 and 4:1. If the AV conduction ratio is constant, then the rhythm will be regular. Otherwise, the RR intervals will be unequal. In this case, the conduction is variable, alternating between 3:1 and 4:1, meaning every third or fourth flutter wave conducts to the ventricles. Before we go on to look at more examples, let's quickly summarize the most important findings. Atrial flutter classically results in a sawtooth pattern, and conduction delay at the AV node typically results in a degree of AV block. First degree atrioventricular block is identified on the ECG by a prolonged PR interval. We can see that approximately 6.5 little squares fit within the PR interval. This equates to 0.26 seconds, which is prolonged. Now in this ECG on the bottom left, the prolongation is less clearly evident. But on close inspection, we can see that the PR interval is indeed longer than one large box, thus it is greater than 0.2 seconds in duration. Type 1 second degree AV block, also termed Mobitz-1 or Wickenbach, is characterized by progressive lengthening of successive PR intervals until an atrial impulse fails to conduct to the ventricles. The lack of conduction to the ventricles results in a pause in the rhythm and the absence of a QRS complex on the ECG. Notice how the baseline PR interval, that is, the first PR interval following a non-conducted P wave, lengthens from beat to beat until a beat is dropped. Although it is obvious in this example, this finding can actually be quite subtle. In less conspicuous cases, it can help to compare the baseline PR interval, which is the shortest, with the PR interval preceding the non-conducted P wave, which is typically the largest. It is important to note that although the baseline PR interval is usually normal in duration, it can be prolonged if there is coexisting first-degree heart block. Another finding typical of Mobitz 1, which is hard to appreciate in this illustration, is an RR interval that progressively shortens. The RR interval is the longest following a drop beat, and then shortens with successive beats until an atrial impulse fails to conduct to the ventricles. The ratio of atrial impulses that are conducted to the ventricles is usually between 3:2 and 7:6. However, this ratio can vary between cycles. Nonetheless, each group begins and ends with a P wave. In this example, the atrial to ventricular conduction ratio is 4:3. That is, for every 4 P waves, there are 3 QRS complexes. Type 2 second-degree AV block is characterized by constant PR intervals and an intermittent failure of the atrial impulse to conduct to the ventricles. Unlike in Mobitz 1, the PR intervals are consistent between all conducted beats. As well, the RR intervals are constant and the rhythm is regular until a beat is dropped. This can be referred to as a patterned irregularity. As in Mobitz 1, the ratio of atrial impulses that are conducted to the ventricles is usually between 3:2 and 7:6. Again, this ratio can vary between cycles. With 2:1 AV block, there is only one PR interval within a grouping. The PR intervals between the groups, however, are constant, as are the RR intervals unless the degree of block is variable. When the degree of AV block is greater than 2:1, the dysrhythmia is referred to as high-grade or advanced AV block. High-grade AV block can be confused with third-degree AV block, however conducted P waves will have a consistent PR interval. With complete heart block, electrical impulses from the atria do not reach the ventricles. Instead, the atria and ventricles are controlled by independent pacemakers. This results in asynchronous activation of the upper and lower chambers of the heart. This is reflected on the ECG as atrioventricular dissociation, in which the P waves and QRS complexes occur completely independently of one another. Now let's take a closer look at this ECG. These are the P waves, and they are occurring at a regular rate, at approximately 115 beats per minute. The atrial rate is based on the underlying rhythm, and in this case, the atria are under control of the sinus node. Note that all of the P waves are easy to identify. This P wave is abutted to the QRS complex, while this P wave has resulted in a distorted T wave. Sometimes, the P wave will not be visible at all because it is completely buried within a QRS complex. It is also important to note that the atrial rate can be irregular, such as when a patient with complete heart block has atrial fibrillation. Now let's take a look at the QRS complexes. They are also occurring at a regular rate of about 27 beats per minute. Note how the QRS complexes are occurring at regular intervals with no relation to the P waves whatsoever. The P waves are simply not conducting to the ventricles and thus do not initiate any QRS complexes. The QRS complexes that emerge are due to an escape rhythm, which is slower than the sinus rate. This is important because AV dissociation by itself is not diagnostic of complete heart block. For example, it can also occur in ventricular tachycardia. So essentially, the ECG has two regular rhythms. The P waves are just marching along minding their own business, and the QRS complexes pop up when they can no longer wait for an electrical impulse to come through. There is no PR interval, just a random space between asynchronous P waves and QRS complexes. In this rhythm strip, you may have noticed that the QRS complex is rather narrow. Well, the morphology of the QRS complexes and the ventricular rate depends on the location of the escape pacemaker. When the block occurs at the level of the AV node and the escape pacemaker is in the AV junction, then a junctional escape rhythm appears with a narrow QRS complex and a rate usually between 40 to 60 beats per minute. When the block occurs below the level of the AV node and the escape pacemaker is in the ventricles, then a ventricular escape rhythm appears. The QRS complex is wide, and the rate is usually between 20 to 40 beats per minute or less. Clinically, patients with a ventricular escape rhythm are usually more compromised. AVNRT is a paroxysmal supraventricular tachycardia that occurs due to a functional re-entrant circuit within the nodal tissue. The electrical impulse goes round and round, typically down the slow pathway and up the fast. resulting in a regular rate of QRS complexes. Note that the RR intervals on this ECG are markedly consistent from beat to beat. The ventricular rate is rapid, usually between 140 and 280 beats per minute. Anterograde activation of the ventricles via the normal pathways from the AV node results in a narrow QRS complex. However, pre-existing aberrancy, such as left bundle branch block, can result in an AV-NRT rhythm with a wide QRS complex. Putting all of that together, we could thus far describe our findings on the ECG as a fast regular rhythm with a narrow QRS complex, all typical features of a supraventricular tachycardia. Now if you look closely, you will notice that there aren't any P waves before the QRS complexes. Instead, there's a terminal deflection right after the QRS complex. Don't let this confuse you into thinking that the QRS complex is wide, because although the terminal wave abuts the end of the QRS complex, it is actually due to the P wave. Indeed, this terminal deflection is actually just the P wave showing up a little late to the party and distorting the end of the QRS complex. Retrograde conduction of a P wave is referred to as an atrial echo beat. In leads 2, 3, and AVF, the terminal deflection can result in what looks like an S wave. Since it's not actually due to the QRS complex but the P wave, it is referred to as a pseudo S wave. In leads V1 and V2, the terminal deflection can result in what looks like an R wave. This ECG reveals both pseudo S waves in lead 2 and pseudo R primed waves in V1. In sinus rhythm, however, none of these appendices should be present. Left bundle branch block can result in several ECG findings, including QRS prolongation, broad R waves in left-sided leads, and QS or RS waves in right-sided leads. When examining the ECG, keep in mind that left bundle branch block can both mimic, conceal, and be caused by myocardial ischemia or infarction. The fundamental electrocardiographic finding of bundle branch block is a wide QRS complex. In adults, complete bundle branch block is present when the QRS complex is 120 milliseconds or greater in duration. On an ECG with a standard paper speed of 25 mm per second, this translates to a QRS complex that is 3 small squares or wider. The morphology of QRS complexes can also provide important clues. The QRS complexes in left-sided leads have a large positive deflection, which can be monophasic or have a notch. However, if Q waves are present in leads 1, V5, and V6, then consider the possibility of myocardial ischemia or infarction. The QRS complexes in right-sided leads consist of a deep and wide negative deflection. Another important finding is that of a prolonged peak R time in leads V5 and V6. That is, the peak R time in leads V5 and V6 is greater than 60 milliseconds, but normal in leads V1 to V3, in which it may not be discernible due to the lack of R waves. Also note that the ST segment and the accompanying T waves can be deflected in the opposite direction of the QRS complex. This is referred to as discordance. Essentially, when the QRS complex is positive, then the T wave is inverted, and vice versa. Finally, with left bundle branch block, the axis is usually deviated leftward. However, it may be normal. The fundamental electrocardiographic finding of bundle branch block is a wide QRS complex. In adults, complete bundle branch block is present when the QRS complex is 120 milliseconds or greater in duration. On an ECG with a standard paper speed of 25 mm per second, this translates to a QRS complex that is 3 small squares or wider. The QRS complexes in right-sided leads have a large terminal R wave, R'. The initial portion of the QRS complex depends on the orientation of the heart and the intricacies of the conduction block, but typically involves a combination of R and S waves. The most characteristic wave morphology is RSR', as seen in this image. This morphology is commonly likened to a pair of rabbit ears. With an RSR' wave, a small R wave is followed by a small S wave before terminating with a large R wave, R'. Note, however, that other possible wave morphologies also exist, such as QR, R', or just R. Thus, the more common RSR' morphology, or rabbit ears if you will, is not present in all cases of right bundle branch block. The QRS complexes in left-sided leads have a broad or slurred S wave, which is greater in duration than the preceding R wave. The peak R time in lead V1 is greater than 50 milliseconds, but normal in leads V5 and V6. The ST segment and T wave are deflected in the opposite direction of the QRS complex. Essentially, when the QRS complex is positive, then the T wave is inverted, and vice versa. Conversely, concordance of the QRS complex with the ST-T wave in a patient with right bundle branch block is suggestive of myocardial ischemia or infarction or other pathology. The fundamental electrocardiographic sign of electrical alternans is the alternating height of consecutive QRS complexes. For example, take a look at leads 2 and V1 in the ECG. There are essentially two sets of QRS complexes that alternate from beat to beat. There is one set of QRS complexes with lower voltage, and another set with relatively higher voltage. Electrical alternans most commonly occurs in patients with a large pericardial effusion. As the heart sways within the fluid-filled pericardial sac, its electrical axis changes, resulting in QRS complexes of varying height. However, it can also occur in patients with other conditions, such as in those with a very fast supraventricular tachycardia. With hypothermia, the classic electrocardiographic finding is J-point elevation, also known as the Osborn J-wave. Note the prominent convex deflection at the junction of the QRS complex and the ST segment. It is most clearly evident in the precordial leads and typically negative in leads AVR and V1. The amplitude of the J-wave roughly correlates with the severity of hypothermia. Although J-waves are characteristic of hypothermia, it is important to note that they can also be present in other conditions such as Brugada syndrome, benign early repolarization, hypercalcemia, sepsis, and subarachnoid hemorrhage. Hypothermia can also cause diffuse slowing of impulse conduction. This can lead to prolonged intervals, such as the PR and QT intervals, and widening waveforms, such as the P waves and QRS complexes. Inspect the QT interval in the ECG. Note that it's prolonged. The PR interval on P waves cannot be assessed due to the underlying rhythm. In regard to the underlying rhythm, marked slowing of the heart rate can occur due to a variety of bradyarrhythmias, such as sinus bradycardia, AV block, and atrial fibrillation with slow ventricular response. In this ECG, note the irregular RR intervals and fibrillatory waves of AFib, yet the slow ventricular rate. One pitfall to be aware of, however, is that shivering can lead to electrocardiographic artifacts, such as waves simulating ventricular tachycardia. Respiratory sinus arrhythmia is a benign phenomenon in which the PP interval varies with respiration. The rhythm is regularly irregular, the heart rate increases during inspiration and decreases during expiration. The variation between the shortest and longest cardiac cycle length, that is, the PP intervals, is greater than 10%, or 120 milliseconds. The heart rate is between 60 and 100 beats per minute, although it may momentarily extend beyond these limits. It is important to note that this is in fact a sinus rhythm. Every QRS complex is preceded by a P wave, which have a constant morphology and are upright in leads 2 and 3. The PR intervals are also constant. The ECG characteristics of sinus bradycardia are essentially the same as sinus rhythm, but at a slower heart rate. An upright P wave of constant morphology precedes every QRS complex, and a QRS complex follows every single P wave. The heart rate in a patient with sinus bradycardia is less than 60 beats per minute. This correlates with an RR interval of greater than 1 second. And finally, the rhythm is regular. That is, the RR intervals remain constant. With a normal sinus rhythm, a QRS complex follows every single P wave, and a P wave precedes every single QRS complex. Although that may sound obvious, the two statements are not equivalent, nor does one automatically entail the other. Another defining feature of sinus rhythm is P waves that are upright in leads 2 and 3 and have a normal wave morphology that remains constant. The heart rate in a patient with sinus rhythm is between 60 to 100 beats per minute. This correlates with an RR interval between 0.6 and 1 second. And finally, the rhythm is regular. That is, the RR interval remains constant. The ECG characteristics of sinus tachycardia are essentially the same as sinus rhythm, but at a faster heart rate. An upright P wave of constant morphology precedes every QRS complex, and a QRS complex follows every single P wave. The heart rate in a patient with sinus tachycardia is greater than 100 beats per minute. This correlates with an RR interval of less than 0.6 seconds. And finally, the rhythm is regular. That is, the RR intervals remain constant. Benign early repolarization and acute pericarditis are both associated with ST segment elevation with a concave upward ST segment. On the other hand, with acute myocardial infarction, the ST segment has a convex upper shape. Widespread PR segment depression is a classic sign of acute pericarditis. With these other two conditions, however, the PR segment is normal. With benign early repolarization, the ST segment elevation occurs in the precordial leads. With acute pericarditis, it occurs in both the limb and precordial leads. And with acute myocardial infarction, the ST segment elevation is localized to the territory of the affected artery. Acute pericarditis is more likely than benign early repolarization when the ST elevation to T wave height is greater than 0.25. With acute myocardial infarction, other findings may be present, such as Q waves, reciprocal ST segment changes, loss of R wave height, or poor R wave progression. An acute inferior STEMI characteristically results in ST elevation in the inferior leads and reciprocal ST depression in the frontal and sometimes lateral precordial leads. With an inferior STEMI, elevation of the ST segment by 0.1 mV or greater occurs in two contiguous inferior leads, including leads 2, 3, and AVF. Pathologic Q waves may also be present in these same inferior leads. If present, the Q waves are usually minimally abnormal in the first 24 hours. Reciprocal changes can involve ST segment depression in the frontal leads, 1 and AVL, and sometimes the lateral precordial leads too, V5 and V6. Depression of the ST segment in leads V1 to V4, however, can indicate concomitant right ventricular infarction. Analysis of right precordial leads is recommended in patients with an inferior wall infarction because of the common co-involvement of the right ventricle. Tachycardia-Bradycardia Syndrome is a manifestation of sinus node dysfunction, one that is characterized by periods of supraventricular tachycardia interspersed with periods of bradycardia. In this example, the tachycardic component is atrial fibrillation. Note the presence of fibrillatory F waves of AFib, as well as the irregular RR intervals. Some other SVTs that can occur include atrial flutter and atrial tachycardia. Following the abrupt cessation of tachycardia, in this example, is a sinus arrest, defined as a transient absence of P waves for 2 seconds in duration or greater. The tachycardic component may also be followed by a sinus pause, escape rhythm, or asystole. Here, the sinus arrest ends with a junctional beat. Note the lack of a P wave prior to the narrow QRS complex. It is also worth noting that the timing of the escape beat is random. That is, the duration of the pause or arrest is not a multiple of the preceding PP interval. Torsades de Pointes is a polymorphic ventricular tachycardia. Note that the QRS complexes show progressive changes in height, width, shape, and axis. Torsades de Pointes translates to twisting of the points. It is quite an appropriate name, as its characteristic finding is a recurring reversal of waveform polarity. A gradual alteration in polarity gives the appearance of QRS complexes that are twisting around the baseline in a spindle-like fashion. VFib is a chaotic rhythm without any discernible pattern. The rhythm consists of completely disorganized electrical activity with undulations of varying shape and amplitude. It's so chaotic that if you were to draw an illustration of it, chances are that your sketch would actually be more organized. Essentially, the ECG just looks like a mess. There aren't any QRS complexes, P waves, or T waves. VFib is one of the most common dysrhythmias that can cause cardiac arrest. Instead of the heart contracting in a coordinated manner, it just quivers and twitches. Circulation ceases, and within seconds it leads to loss of consciousness and apnea. This is a very important rhythm to recognize because it requires immediate action. It will deteriorate to asystolia and death if not treated rapidly. Fortunately, ventricular fibrillation is one of the shockable rhythms. Cardiopulmonary resuscitation should be provided while defibrillator is being obtained, and a shock should be delivered once the rhythm is identified. Following the shock, CPR should resume for 2 minutes before another pulse and rhythm check is performed. To reiterate, CPR commences immediately after the shock is delivered. It is essential to keep interruptions in CPR to a minimum. For more information on management, please check out the latest ACLS algorithms. Now just one more thing I would like to add in regards to the ECG. Ventricular fibrillation can be classified as coarse or fine. In coarse VF, fibrillatory waves are 3 mm or more in amplitude. In fine VF, the fibrillatory waves are less than 3 mm in amplitude. When the amplitude of the waves is low, the ECG reading may be confused with asystole. The distinction is important because asystole is not a shockable rhythm. Wolff-Parkinson-White Syndrome can manifest with several different findings on the ECG, the most classic of which is the delta wave. But there is something else I'd like to discuss first. Take a look at the PR interval. In Wolff-Parkinson-White Syndrome, an accessory pathway bypasses the AV node and results in an early onset of ventricular depolarization, also known as pre-excitation. The lack of AV nodal delay is reflected on the ECG by a short PR interval, with a duration of less than 120 milliseconds. So essentially, because of pre-excitation, the QRS complex appears sooner than usual. Early depolarization of the ventricles occurs outside of the conduction system, that is, via slow muscle fiber to muscle fiber conduction, which results in a slurred upstroke of the QRS complex. This slurring of the QRS complex is referred to as a delta wave, the classic sign of Wolff-Parkinson-White syndrome. Also note how the QRS complex is wide. That's because it is a composite of ventricular activation via both the bypass tract and the AV node. The initial portion of the QRS complex, the delta wave, is the result of aberrant ventricular depolarization via the accessory pathway, while the terminal portion reflects normal ventricular depolarization via the AV node. Now the keen ECG aficionado may have noticed that this is a type E pattern due to a right-sided bypass tract. The deep S wave in lead V1 indicates right to left-sided conduction. Ventricular depolarization begins on the right side of the heart and then spreads to the left. A couple pitfalls to keep in mind are that the ECG correlates of Wolff-Parkinson-White syndrome may not be present during sinus rhythm and can also vary from day to day. As well, the Wolff-Parkinson-White pattern can mask the findings that can occur with myocardial ischemia or infarction and other pathologies.